So I'm going to talk about workflow and efficiency with the Pentacam axial length, AXL, and a few reasons why I added the Pentacam AXL to my clinic. Anybody in the audience have the original Pentacam? Yeah, I was like you. I had the original Pentacam. We had our first Pentacam back in 2005, and one of the first units. And what's amazing is that unit has been such a workhorse. You know, to have a piece of ophthalmic equipment that's relevant, you know, over 13 years later or 12 years later is truly amazing. And what's been great about Oculus is they've been very good about upgrading it. You know, every few years there's been software upgrades. You know, when I look at my other biometer for, let's say, the IOL Master, we've had about 5 units that we've had to buy to keep up to date. You know, the technology's kept on getting outdated, and so the Pentacam has been truly a robust piece of equipment in our clinic, and it's been our go-to corneal refractive diagnostic tool. So anybody that's having corneal refractive surgery in our clinic gets a Pentacam. And it's been great to now, as we've all seen, is cataract surgery is now refractive surgery. And so to get the best refractive results, I think we truly need refractive diagnostic with our biometry. So we added that to kind of up our game in cataract surgery. We've also seen some efficiencies with that. I'll explain that. You know, it's a one-stop for our patients. That posterior corneal measurement, I think, is crucial. If you're going to be guiding a femtosecond laser off of preoperative diagnostics, you want to know what you're treating. You know, right now with traditional biometry or corneal analysis, if you're only looking at Ks, you may not really be placing that femtosecond LRI in the right place. And I think with total corneal measurement, you can guide that placement of that femtosecond incision. So that links to our femtosecond laser, the Pentacam, which is great, and it's all the information I need to make a good decision. You know, we've seen many advancements in cataract surgery over the past 5 years: femtosecond lasers, intraoperative aberrometry, new lenses. And one thing that all these advancements have in common, they've all increased time. It's pretty rare nowadays to add something that's going to step things forward, but also decrease time. And what I've seen, though, is that with the Pentacam AXL, it's truly a step forward in cataract surgery, but it's also efficient in saving time. Traditionally, we're doing 3 main measurements for cataract surgery. We had the biometry, axial length measurement, topography or tomography, and a macular OCT. And each measurement is about 5 minutes, so at least 15 minutes in preoperative diagnostics for all our cataract surgery. You know, now if you can eliminate one step, that's truly eliminating 30% of the time, 5 minutes, and that's significant if you think about case after case of all the cases you're doing for your patients, putting them through one less step, for your staff, putting them through one less step. I think that alone pays for itself over time. Other things that are sort of indirect as far as efficiency, you know, having the answers that you and your patients are looking for, I think is crucial. What's nice is it has this sort of pathology scanner that gives you sort of a report from this eye compared to normative data. And what's nice is, number one, it's good for the surgeon to get a good quick glance and see what's going on, but you can empower your staff and delegate some of this and start the education process earlier. You know, we have a surgery scheduler and a cataract counselor that can use the Pentacam data and start the discussion with the patient. Say, okay, it looks like your eyes have normal characteristics. It looks like you have astigmatism. Looks like you may be a candidate for XYZ lenses. And the more you can delegate, the more efficient you're going to be within your clinic. You know, with a traditional biometry scan, it may not be able to understand the pathology, but with a Pentacam, you can understand that pathology before you start discussing things with the patients. Other things you see, you probably always get this. Patients will say, Doc, are my cataracts ready? It's nice to have an objective measurement to start that discussion. You can see that over time you can show how has the eye changed. You can say, okay, look at, instead of saying, well, you have about a 1+ NS, you have something now, an objective measurement that you can share with the patient to help guide that patient and yourself through that decision process. I think that gives the patient confidence that there is pathology there and that you're going to treat it appropriately. Also, you probably hear this too, doctor, do I have astigmatism? And when you start talking about toric lenses, they're thinking, well, do I have that? Do I need that? Nobody's ever told me I have astigmatism. What's nice is with this preoperative cataract screener, you can say, okay, here's your astigmatism. This is how much. You can also show on the same screen, this is your cataract. We can solve 2 problems with 1 procedure. We can take the cataract out and treat the astigmatism. I think it's a great display tool to show to your patients and help them understand what's going on and what you're trying to treat. As discussed, the total corneal power is crucial. Understanding that before you're getting in the operating room can help give you that confidence that you're picking the correct toric lens or the correct LRI for that patient. Also, you can understand is there spherical aberration or regular astigmatism, which is an important screening tool. Is this patient going to do well with an advanced technology or multifocal lens? What's interesting is, which measurement or which screening tool would you be more confident in? You look at a traditional method, the K scans might show a little X that maybe there was a regular astigmatism or didn't get a good scan. Now with the Pentacam, you get a true analysis of what's going on in the cornea. You can be confident that it was a good scan, that there is astigmatism there, and that you're going to treat it with your approach. Also, I think premium lenses do require premium diagnostics. What's great is this gives also a corneal optical density reading, and you can understand, is there basement membrane disease? Did they have previous refractive surgery? Is there scatter going on? You don't want to recommend an advanced lens if there's some other pathology going on, so this gives an objective measurement to what's going on in the cornea. Corneal power information. I've been a big fan and advocate of intraoperative aberrometry, but I will say that intraoperative aberrometry is not perfect for everyone. It is there's a skill to it. It takes a little bit more time. There's also variables that can make that measurement not accurate. And to have 2 measurements of total corneal power, number 1, measuring it before you getting into the operating room, but number 2, in the operating room, gives you that confidence. I think it also, in some cases, it can help eliminate that step. Like I discussed earlier, linkage to the femtosecond laser, you know what you're treating before you get into the operating room, and you can translate that. Also can translate that information with sort of measuring the ocular rotation, so you're making sure that you're treating on axis with that astigmatism. As been discussed, there's a comprehensive IOL calculator with a lot of different formulas depending on what you're most comfortable with. The most recent is the addition of the Barrett formula. Also, you get this great printout that can guide you on not only the astigmatism magnitude, but the axis, which is crucial, so it can understand where your incision is placed, how is that going to affect your treatment and lens choice. We also did, anytime you add a new piece of equipment, you want to make sure you're confident in it compared to your traditional technique. So we compared this to our IOL master as well and found that the devices were interchangeable. There were certain cases where the corneal power was different, but I felt more confident in the Pentacam measurements, the IOL master measurements, and those cases that did deviate did show that the Pentacam was more accurate in those cases that did deviate. So the axial length measurements were interchangeable, but there were some differences in total corneal power, which you would expect based on the technology. So in summary, I think it's definitely improved quality of care. It's enhanced clinic efficiency. It's given physician confidence to deliver the best outcomes. It's also giving patient confidence in the surgeon to achieve the best result. Thank you.